You notice in your limbs that you have developed pain every time you exercise, accompanied by a cold and numb sensation and a reduced pulsation in your arteries and veins. Worried, you decide to visit the doctor, and as it turns out, you've got chronic limb ischemia. With a lack of blood flow putting you at high risk for amputation and mortality, you need urgent care. But unfortunately, traditional treatment options are not suitable for your case. Surgical interventions are too invasive, pharmacological therapies are ineffective, and lifestyle counseling just takes too long. But what if you can treat it with DNA? How, you ask? Well, let's find out. Welcome to the genetic spaces of stuff and things. Chronic limb ischemia occurs when clogged arteries limit blood flow to peripheral areas due to fatty deposits reducing the lumen of blood vessels. As these deposits are acquired from lifestyle factors, their long-term effects makes finding an effective treatment a challenging task. But what if we could promote the growth of new blood vessels to improve circulation? By inserting the gene that encodes for blood vessel growth, we can alleviate the clinical symptoms from ischemia. First, we need to identify what that gene is and how it can be inserted into the body. The ideal candidate for this purpose would be the Vascular Endothelial Growth Factor, VEGF or VEGF-A, due to its localized action which minimizes off-target effects. This specificity stems from its high affinity for tyrosine kinase receptors only located on endothelial cells. VEGFR2, aka FLK1-KDR, induces the primary angiogenic signal through the PLC-gamma PKC-MAPK pathway, while VEGFR1, aka FLT1, plays a regulatory role by sequestering VEGF proteins and induces a weak angiogenic signal. Both receptors contribute to endothelial cell proliferation and migration, a process known as angiogenesis. This branch of medicine falls under nucleic acid-based therapies, whereby exogenous nucleic acids are employed to induce genetic modifications and evoke a physiological response in the treatment of diseases. Now, how exactly do we insert this gene into the body? Delivery systems, often viral vectors, are used due to their high transduction efficiency, but their side effect profile isn't as great. And the safer alternative, non-viral vectors, may also be used, but they have low transfection efficiency. Pioneering trials have taken the non-viral route by utilizing plasmid DNA in preclinical trials involving ischemic rabbit models and early clinical trials conducted with an elderly female patient. It contained a cDNA encoding the VEGF165 isoform, the most biologically abundant isoform, and a cytomegalovirus promoter to drive its expression. This synthetic construct allowed for the gene to be transcribed into mRNA and then translated into protein to induce angiogenesis, a process coined as therapeutic angiogenesis. Along with success, these researchers had made a key discovery. High transfection efficiency was achievable from non-viral vectors. But how was this possible? It turns out that the N-terminus of the translated protein product contains a secretion signal, inducing its active secretion from successfully transfected cells. This produces a profound physiological response by activating angiogenesis in neighboring endothelial cells. Now that scientists had determined its feasibility and safeness for use, their next objective was to determine the long-term effects and viability with a large cohort. In a randomized clinical trial conducted in 2010 by a group of Russian collaborators, 100 patients of chronic lower limb ischemia were recruited. These patients were not suitable for surgery and had long-term symptoms of moderate to severe pain. Grouped at a ratio of 3:1 treatment to control, the treatment group received 2 intramuscular injections of the nucleic acid-based therapy administered 14 days apart, whilst the control received standard treatment. The nucleic acid-based therapy itself involved the same synthetic construct used in past trials, though as a supercoiled plasmid in place of the normal plasmid, due to its more compact structure. Collectively, this was termed PCMV VEGF165. With follow-up taking place at 1 and 2 years, notable observations were seen. Blood flow characteristics and pain-free walking distance had increased with time, notably so for the pain-free walking distance, which had achieved statistical significance for the treatment group. Interestingly, the intervention was particularly effective for patients at the most advanced stages of the disease, who improved 828% in the pain-free walking distance by the end of the study. Furthermore, pain symptoms were relieved in treatment patients, and no adverse effects were associated with the gene transfer. By excluding patients with ischemia-induced tissue loss, such as open sores or dead tissue, and only including patients of pain symptoms, this study uncovered the effects of gene transfer as an early interventional pain regulator for the disease, while simulating the real-life implications of this treatment via treadmill tests. Overall, this study made a significant contribution to the current scientific literature, and despite showing no reduction in amputation nor mortality rates, the observed pain relief from the study prompted the launching of the therapy in the Russian market, now called neovasculin. It's time to welcome a new era for medicine by delving into the field of genetic modification. With proper regulations addressing its ethical concerns, the development of nucleic acid-based therapies has the potential to treat countless diseases and significantly expand the current treatment pool, unlocking boundless possibilities for our future.